This is much less controversial.
We'll see.
Franz asked me also to talk a little bit about comorbidity and the whole concept of screening and the age and decision making and basically when to stop screening. So let me start by a concept graph. Basically, prostate cancer is a race between aging and dying from some other cause on the x-axis or disease progression on the y-axis. I think we all recognize virtually 80% of men in their 80s have microscopic evidence of prostate cancer, so I would argue there's a race going on between these two. We have the rapidly progressing tumors that kill people. We have the slowly progressing tumors that don't seem to do anything and people die from some other cause. Before screening, we urologists saw all the purple people. I changed the color for you, Laura. We saw the purple people because they were the ones who presented with metastatic disease. They were the ones we were asked to do orchiectomies on. We didn't see many of the orange people who were the ones who died of other causes. What's changed, certainly in the US with mass screening, is we've basically doubled or tripled the number of men. We found a lot more orange men and we found a lot more purple men. But what are we really after when we talk about comorbidity, when to stop? We're trying to estimate that time from aging forward, where in fact if you screen during that period, you're only finding orange men, i.e. men who are never destined to die from their disease. Again, we would agree if screening works, Andrew's just finished telling us this is the age range we should be screening in the earlier years, and at some point in aging, it remains undefined, and let's see if we can do that. From that point forward, the net gain is so marginal, it's not worth doing. So the question is, can we quantify this graph? Well, what have the screening trials showed? I think we've just had a long discussion that somewhere, I won't argue whether it's 10, 11, or 12 years, but it's somewhere in there that screening provides very marginal benefits, and if it's going to benefit, it will grow exponentially from that point forward. So we know that that magic quantity of 10, 11 years is something that, and it's borne out in a number of trials. You could argue that's the same trials. So where can we get that information? Well, we can get from life expectancy tables. Problem is, Jerry just talked about the healthy survivor bias, which affects some of the trials. We can look at computer simulations. They, of course, depend on the accuracy of the input of the data. We can look at various cohort survivals, but they all depend on how the cohort is selected. And then we can look at a tool that actually measures comorbidity. So I'm going to quickly run through these. This is the US life expectancy. I did it for this talk. I actually checked the Swiss men do a little better than the US, but this is all cause. This is not healthy men. So if I would argue, if you did it from a purely point of view of a government mandated, you don't screen after 10 years of life expectancy, you'd stop at age 75. Laurie would argue there's an 80-year-old who's skiing in Canada, he should have the right to, etc., and I won't argue with him. But from a government point of view, you would argue it makes no sense beyond 75, from a mass screening paid for by healthcare dollars. I just contrast that to what we're actually doing in the US. You can see a good number of men are still being screened beyond that, but at least by age 85, even the American urologists are recognizing that there's probably less of a return on that benefit. What do we know about the natural history of disease and the impact of treatment? Well, I'll take you back to a decision analysis I published in JAMA in 1993 that focused on some of those early concepts. This was a Markov model, again, a computer simulation. If you were 60, 65, 70, and 75, what happens if you did watchful waiting, radical prostatectomy, radiation? Well, after 10 years, these were the following outcomes expected. As you can see, when you start getting to 75, dead from other causes is beginning to dominate. Alive with no evidence of disease was still a significant portion. It's the dead of cancer or treatment, these little ones, that really did not have a dramatic difference. And you say, well, that was just a computer model and was thoroughly trashed back in 1993. But if you look at the Axelson data, the model actually tracks almost exactly what the Bill Axelson data said. So it wasn't as crazy as we talked about. But again, this issue of 75 and above. When we look at outcomes from here, many of you have seen my graphs. Death from high-grade disease is very prominent in younger men. As you age 60 to 69, it's still significant among the 8 to 10 group. And even 70, 74, high-grade disease is still a significant killer. So already just magically stopping at 75, I would argue you will miss some men beyond that who will die of aggressive prostate cancer. But conversely, the number of men with the low grades, and I won't quibble, many of these have become Gleason 6s. In the pre-PSA era, this is 20-year horizons. As we told you in more modern data, the number of men dying within 10 or 15 years is relatively modest. So let's talk about comorbidity. There have been a number of indices developed. Shelley Greenfield is still at work. He developed an index of coexistent disease, which was published in Medical Care in 1993. Mary Charlson developed her score and published it. She was into researching breast cancer, so that was developed for hospitalized patients with breast cancer. And for those who don't know the Charlson Index, those in Group 1 are awarded 1 point. Any one of these diagnoses gives you 1 point. These diagnoses, hemiplegia, moderate to severe renal disease, diabetes with end organ damage, give you Group 2, give you 2 points, leukemia, lymphoma. As you can see, these are already pretty sick people. And the problem with most comorbidity scales is by the time you have 2 comorbidities or more, none of us in our right minds are screening these patients already. So what happens is most of the comorbidity scoring systems basically quantify and select for patients that are much sicker than we even dream of screening and treatment. So they're not that useful. Group 3, just to complete the Charlson Morbidity Index, when it was originally developed, actually had acquired immunodeficiency system, the disease as bad as metastatic disease. We validated this for the first time back in 1996 when we looked at these various comorbidity indices, and we demonstrated that, in fact, they were predictors of death from prostate cancer. You can see that it did not predict death from prostate cancer, but in terms of all-cause mortality, the Charlson score actually worked very nicely to separate those curves. This was recently republished and revalidated by a group from UCLA. Shelley Greenfield is one of the authors right here. He developed, he's one of the gurus in the development of comorbidity indices, and they've recently published an improved prediction of long-term other-cause mortality for prostate cancer. And again, they show the same issue. These comorbidity scales are useful in separating patients who are likely to die of other causes. The problem, I would argue, is it's primarily a research tool, not terribly useful clinical practice, because you can notice 0 to 1 to 2 Charlson. These people have good survival. Everybody else is dying within 10 years, so anyone with a Charlson score of 3 or more is unlikely to benefit from screening. The problem is you already know that. You've already selected these patients not to be screened. This is the revised Charlson Index, so therefore to get a score of 6, you have moderate to severe liver disease, metastatic solid tumors, lymphomas, leukemias. Most of us do not screen these men. To get a score of 0, 1, or 2, basically it's only things, mild liver disease, peripheral vascular disease coming on down. These are the things that will buy you 1 or 2 scores in a Charlson system nowadays. What is the survival of age impact and comorbidity on survival? Well, again, this is what I'm saying. These are the graphs of competition between prostate cancer death and death from other causes, adjusted for what I would argue contemporary screening in the United States. This is using SEER data. This is looking at patients who have been diagnosed with prostate cancer and not treated for their disease. But remember, there's an extraordinary selection bias afoot here. Only those people who are healthy enough to get a biopsy could even get the diagnosis in the first place to not be treated, or at least the majority of the screen-detected folks. I want to focus, however, when you look at the high-grade disease, poorly differentiated, notice even at age 80, you're still seeing significant death rates from prostate cancer. So to use age as a solitary criteria, unfortunately, still will miss some disease. Comorbidity does have an impact. And that's what we showed here, that in fact for the younger men, when you go with higher comorbidities, 1 and certainly down to 2, you can see the death rate from other causes increases dramatically. But when you look at men with Gleason 8, which is here, even those with significant comorbidities will have a 10 to 15% death rate from prostate cancer within 10 years. So yes, Comorbidity analysis is excellent from an analysis point of view from data. From a practical point of view, I think most urologists have already done that selection in their mind in terms of who to choose to get a PSA and who you choose to biopsy versus those you do not. There's an extraordinary healthy selection bias among we as urologists, and again, betting back to our earlier discussion, when people have to make recommendations from a population point of view, they are including all those patients with Charlson's 3, 4, 5, 6, and 7. We have mentally excluded them. They're already off our radar screen. And we've already targeted that population with Charlson 1 or 2. So in fact, if we were to argue with the U.S. Preventative Services Task Force, you would probably all agree. You have to have a Charlson score of 0 or 1 to even qualify for PSA testing, because if you have a Charlson score 2, 3, or greater, the likelihood of you surviving 10 years is fairly modest, and therefore PSA testing is probably inappropriate for you. We already practice that. And as I said, these are the tools we might use to implement that. And that, I believe, is the take-home message from that is screening and localized treatment will have little impact on survival, I would argue, after age 75. I don't think we have much discussion here on that. Men with 1 or 2 comorbidities will have little benefit from screening when you push that age down a little further to 70. Most men with significant comorbidities do not even present for screening and treatment. And unfortunately, men with poorly differentiated disease at any age face a significant risk of dying from their disease because bad cancer is still bad cancer. And with that, unless anybody has questions, I think everybody wants coffee.
Well, thank you very much. Are there any questions? Maybe you can... Just one thing I would like to know.
They want coffee.
No. In Switzerland, at least, I have the idea. The recommendation is one thing, but what the urologists out there are doing is another thing. And I think we, at least in our country, we have to blame ourselves a little also, because they do PSA at any age, they do radical prostatectomies at any Gleason score at any age, more or less. And how is this in your country, or maybe in Sweden and other countries?
Let the Swede. I think the data I've already presented on the heavy screening in the above 80 crowd has already been shown. This is the problem. And this is where we as urologists have to take some responsibility from the reaction of the U.S. We blame the U.S. Preventative Task Force for throwing the baby out with the bathwater, but you can't argue that they have some concerns about the use of public funds.
Okay, now I double-checked the program, but I think we are ready for coffee now.